Hello and welcome to today's video where I'm going to be discussing the hepatitis B virus. This virus increases the risk of developing significant liver disease and developing hepatocellular carcinoma. Both are very devastating diseases, so it's important to understand this disease, detect it early in your patients so you can treat them as early as possible. The virus is part of the hepatinovirus family, and this nomenclature is convenient. It already has the letters D and A within it, and this is the type of virus it is. It's a DNA virus. Now, as you're aware, some viruses are single-stranded DNA, others are double-stranded DNA. Hepatitis B is a little different. It's actually partially double-stranded DNA. Some parts of it, as I'm highlighting here, is double-stranded, whereas you look at other areas, it's single-stranded, making this a very unique virus in this way. It has a nucleocapsid core that surrounds it, and this is made up of what's called the core antigen. Also within the nucleocapsid, you have other antigens which are known as the envelope antigen. This antigen is very important when you try to detect whether or not the virus is actively replicating or whether it's remaining dormant. And this is important when we try to assess a patient with chronic liver disease and see whether the treatment is working and whether we're keeping this virus under control. Around this nucleocapsid layer, we have the envelope. And this envelope is studded with a specific antigen, which is known as the surface antigen, because of course it's on the surface of the virus. And this surface antigen is very important when we're detecting infection and even immunity. So this is the structure of the hepatitis B virus. All these antigens become very important when we start looking at how to diagnose and detect whether the patient is actively having a virus infection in their body. So very important to keep all of this in mind, and we will return back to this structure repeatedly to help really make it easier for you to memorize the different diagnostic methodologies for the hepatitis B virus. Now that you have a better understanding of the structure of the hepatitis B virus, let's now begin talking about how it gains entry inside the cell and it replicates. So here we have a cell membrane of a cell and the nucleus inside. On the cell membrane, there is a specific receptor which the hepatitis B virus attaches to. This phase is called the attachment phase. Once attached, the nucleocapsid gains entry into the cytoplasm of the cell. After entering the cell, it undergoes a process of uncoating, which simply means it loses this nucleocapsid, and now you have this partial double-stranded DNA running around the cytoplasm. This double-stranded DNA will then find its way into the nucleus. Once in the nucleus, the remainder of the DNA is completed to create what's called a covalently closed circular DNA, or cccDNA. And this just means now you have a partially double-stranded DNA and you went to a complete double-stranded DNA. This cccDNA is used as a template for transcription. And when you get this transcription, you begin to produce all this mRNA using all the host cell machinery. Eventually, like as you probably understand with the whole process of transcription, the mRNA comes out, and then you have translation. So this shouldn't be anything new to you. What does it translate? Well, it begins to translate all these core antigens and the envelope antigens. So now we've created that kind of nucleocapsid for the virus. Next, the virus will then create something called the pre-genome RNA, which is a RNA version of the entire DNA genome. This pre-genome RNA will go into this newly created nucleocapsid. And once it enters the nucleocapsid, the viruses use the RNA as a template to create DNA. So this is interesting because typically we're used to DNA creating RNA, but this is RNA creating DNA, and this is known as reverse transcription of DNA. Once this happens, the RNA degrades, and the virus will then create a second partial strand to recreate that partial double-stranded DNA. So now we got the nucleocapsid, we got the partially double-stranded DNA. From here, the virus can either go back into the nucleus and kind of start the process all over again, or it can go forward into the Golgi. The virus particles that go through the Golgi then acquire the classic envelope with the surface antigens around it. And finally, and so this is acquiring the envelope. And finally, the virus leaves through a process called exocytosis. Hepatitis B virus is transmitted through a variety of different methods. One method is from mother to child, and this happens at the time of birth. There are several factors which increase this risk of transmission, such as the mother being positive for the hepatitis B E antigen or having a high viral load at the time of delivery. However, you can reduce this risk of transmission by giving antivirals to the mother prior to delivery or vaccinating and giving hepatitis B immunoglobulins to the child within 12 hours of delivery. This intervention can reduce the risk of transmission by up to 95%. Hepatitis B is also transmitted through sexual contact, and within the US, up to 35% of cases are transmitted through this methodology. Therefore, as you could imagine, hepatitis B is more prevalent in men who have sex with men, sexual workers, and also heterosexual people with a lot of sexual partners. Percutaneous inoculation is another method, and this is why hepatitis B is prevalent with people who use IV drugs, and it's also a risk factor for acupuncture, tattooing, and piercing. Therefore, it's very important to use clean needles when undergoing these procedures. Blood transfusion is another method for transmitting hepatitis B virus. Although this is less common due to screening for the surface antigen, antibodies to the core antigen, and detecting hepatitis B virus DNA. Although hepatitis B virus DNA finds more, due to the high cost, this is seldomly used. Blood exposure is another method. Hepatitis B virus can actually survive outside the human body for a long period of time. That's why blood exposure to even minor breaks in the skin or mucous membrane can transmit the virus. Also, household articles with blood, such as toothbrushes and razors, is also a risk factor. Needle stick injuries is another risk factor, and this is why it's important that you're careful with needles and you get vaccinated for hepatitis B. And finally, organ transplant is another method, although this is less common because donors are routinely screened for the hepatitis B surface antigen. Now let's talk about the epidemiology of the hepatitis B virus. Hepatitis B virus is a considerable global health issue. It's highly prevalent in sub-Saharan Africa, with the primary method of transmission being from mother to child. It's also moderately present in Northern Africa, in Asia and Eastern Europe, as well as South America. In these locations, sexual contact is the primary method of transmission. Its prevalence is low in areas such as North America, Europe, and Australia, with the primary method of transmission becoming IV drug use. Interestingly, the prevalence of hepatitis B virus is increasing worldwide. However, it seems to be decreasing in the USA. Still, although it's decreasing in the USA, at this time there's about 2 billion people exposed with evidence of some sort of past or present hepatitis B infection. According to the WHO, in 2015, there was 257 million carriers of hepatitis B worldwide, and up to 887,000 people died from hepatitis B related liver disease. Therefore, as I stated earlier, this is a significant global health problem, and vaccines have been playing a great role in decreasing the incidence and reducing the morbidity and mortality related to this disease.
Hi everyone, sorry to interrupt. I know you're studying hard. I just wanted to pitch our new podcast format for this YouTube video. The Study Spot Shortcast will condense this in-depth video into 5 high-yield points in just 10 minutes. This will give you the most important points quickly and efficiently when you're on the move. Just search for the Study Spot Shortcast on Spotify. And now, back to the video.
Many learners find the diagnosis of hepatitis B challenging, and that's primarily because of all the serum markers involved. However, I'm going to try to present a way to understand it, which I hope it helps. And it's important that you understand it well because it is a high-yield topic for the USMLEs, which you will most likely get a question on. So to understand this, we're going to create this table here. This table shows the months after exposure to the virus. So the first serum marker we'll look at is the serum antigen, the surface antigen, which, as you recall, is found on the outside of the virus envelope. And whenever you see surface antigen, I just want you to think infection, because if you see this in a patient, that means they have an infection. The surface antigen typically presents about 1 month after exposure, which is just a little bit earlier than the symptoms, and symptoms typically present 2 to 6 months. And the surface antigen typically levels off at 6 months, but for an unfortunate few who develop chronic hepatitis B, it can persist for longer than that. Now, of course, if you have a surface antigen, your body will make antibodies to fight it. And so the surface antibody is associated with immunity. So whenever you see surface antigen, think they have an infection. If you see surface antibody, think immunity. The surface antibody develops around 8 months. And so as you can see, when you look at this graph already, is this 6 to 8 months is an interesting time period. And it's known as a window period. And the reason why it's called the window period is because say you tested a patient at the 7-month mark, you would get surface antigen is negative because they've gone, and the surface antibody is negative because that hasn't been developed yet. And so you will incorrectly conclude the patient does not have hepatitis B. So this is where the core antibody comes in. And as you will recall, the core antibody is found on the inside of the virus. Interestingly, for whatever reason, we cannot detect the core antigen. All we can detect is the core antibodies. Now, the total core antibodies includes IgG and IgM, and just kind of like a chronic surface, patient with chronic hepatitis B, it persists for life. However, there is an IgM subset which does go away after 8 months. And as you can see, this is going to be important this is going to be an important marker during the window period, because although you don't have a surface antigen or a surface antibody, you definitely have these core antibodies that are present. So IgM, what I want you to do with IgM core antibody is associate it with an acute infection or the window period, because as you can see, it goes away after 8 months. So if it's positive, that means you're somewhere, within the 8 months of exposure. And of course, if it's positive, it also can suggest a window period. And the total core antibody, I want you to associate with recovery. And what this means is the patient at one time was exposed and their body fought it off, and they don't tend to have an active infection, but they were exposed at some point. Now, the next one is the envelope antigen, which we can detect, and that's this antigen that's found on the inside. The envelope antigen comes pretty early, but it does just kind of dissipate quickly as well. Now, if it persists for longer, you can see it tends to go up and down. So, if you have this chronic infection, it'll wax and wane over time. And that's because the envelope antigen is associated with replication of the virus, which is a marker of infectivity. So if you see high E antigen, that means that the virus in this patient is actively replicating and the patient can transmit. So it's associated with a high viral load as measured by hepatitis B virus DNA, and the patient is at high risk for transmission. So this is specifically important for pregnant ladies and people with chronic infection, and you want to get an idea of how the virus is replicating inside the body. There is antibodies do develop for the E antigen, and they come out soon as kind of the E antigen goes away, the antibodies to the E antigen start to develop. And because, again, they're antibodies and it's a measure of immunity, it's a measure used in chronic hepatitis B to signify remission, and the patient is doing well. So this is a graph, so this is good to know. What I want to do now is I want to look at it in another way, present it to you in another way to help understand how do you actually use it for diagnosis of infection and immunity. So now let's look at how do you diagnose a patient with infection. So as you recall, the surface antigen is associated with infection. So of course you would expect the surface antigen to be positive. Now the surface antibody is associated with immunity. So if somebody has an infection, you would expect the surface antibody to be negative, otherwise they'd be immune. Now, as you also remember, the total core antibody is also going to be positive because that's always present. So once you've diagnosed a patient with infection, which is primarily that the surface antigen is positive and the surface antibody is negative, the next question you need to answer, well, is this an acute infection or a chronic infection? So there are specific serum markers which help with that. So as you remember, IgM core antibody is associated with acute. So it'll be positive with patients who have an acute infection, and you will be negative with patients who have a chronic infection. And keep in mind, this is also positive in the window period, which is also an acute period. Now, for the chronic patients, the surface antigen is typically positive for more than 6 months. So that's the definition of chronic hepatitis B. And during this time, the envelope antigen and the HBV DNA, which is the viral load, these tend to become more important because they help you determine whether the virus is active versus inactive or dormant in that case. And that helps guide a lot of decisions for treatment, as we'll discuss later. So this is as simple as it is. Infection, look for the surface antigen should be positive, surface antibody should be negative, and then look at your IgM core antibody, and if that's positive, it's acute. If it's negative, you're looking at a chronic infection. Now let's take a look at immunity. So sometimes you just want to know, is my patient immune? So there's two ways to be immune. Either they could be vaccinated, or they can have natural immunity, or also called recovered, which means they got exposed to the virus and their body was strong enough to fight it off. So as you remember, the surface antibody is associated with immunity. So if they're vaccinated, they should have a surface antibody positive. And if they have a natural immunity, they should have a surface antibody positive. But is there a way to distinguish between these two? Well, that's where the total core antibody comes in. So if the patient also has total core antibody, that means they were exposed in the past, and so that means they developed a natural immunity or they recovered from the virus. So I hope this understanding, associating each serum marker with what they represent, and then from there kind of deducing how to diagnose different types of infections and immunity. I hope that does help you understand this, grasp this, and when you get these questions on your USMLE, you get them all correct. So now let's actually talk about acute hepatitis, how it presents, and how we could potentially treat it. Clinically, a majority of the time, like around 70% of the time, it'd be subclinical and patients won't feel anything. 30% of the time, it can present as ecteric hepatitis, which is, the patients have anorexia, they feel very nauseous, they're jaundiced, they can also experience right upper quadrant pain, and this lasts about 1 to 3 months, and they typically get over it, and then they just kind of move on with their lives. Unfortunately, you can get fulminant liver failure due to acute hepatitis, but that is about less than 1% of the time. So majority of the time, adults especially will tend to clear it. From labs, you will get ALT, which is greater than AST, and this can be ranging in the thousands. So if you do see, liver enzymes in the thousands, do screen for hepatitis B. It's very important to take a look at that. Bilirubin is another thing you check. For hepatitis B, it's variable. Sometimes it can be elevated, sometimes it can't. Highly elevated is a poor prognostic sign. And you also want to check out the INR. Remember, this is a measure of the liver function, and this is also a prognostic sign. Obviously, if it's elevated, it means the liver took a bad hit, and these patients aren't going to do well. So acute hepatitis can progress further. In the perinatal phase, about 90% of the time progresses. So high percentage progression rate for the neonates, especially when their mother has it and it passes it on. Adults, less than 5%. So adults don't tend to progress as much as perinates. So what does it progress to? So, acute hepatitis can develop into chronic liver disease. And then if this chronic liver disease can progress to cirrhosis, and of course cirrhosis is a very difficult disease to manage, and then this can produce either hepatocellular carcinoma and then death from liver failure or from that cancer. So this is something that can eventually lead to death, so it's important that these patients are screened and identified. So what are some factors that can increase risk of progression? So there are specific factors, specifically co-infection with other viruses. So co-infection with hepatitis C virus is actually very interesting. So it turns out that hepatitis C virus can compete with hepatitis B virus for replication, so they can actually kind of cancel each other out, and you have less liver disease in patients who are contracted both. What's interesting though is, although you can decrease the risk of liver disease, it still does increase the risk of hepatocellular carcinoma and increase the risk of fulminant liver disease. So this is a little bit dichotomous and strange relationship between hepatitis C virus and hepatitis B virus. Hepatitis A virus, say a patient has hepatitis B and then they get hepatitis A virus, that increases the risk of fulminant liver disease. So that's why it's important, anybody who's got hepatitis B virus, to make sure you vaccinate them for the hepatitis A, because it can be very difficult for them to manage that virus if they do get it later. Hepatitis D virus, one of the most interesting viruses. It cannot cause disease on its own. It needs to kind of tack onto hepatitis B, and people who do get this, both of them, are at increased risk of fulminant liver disease. Beyond just progression, there are some extrahepatic manifestations. Since it's a virus, many viruses mess with the immune system. It can throw off some immune complexes, which cause a lot of problems. So patients with hepatitis B are also at risk for polyarthritis nodosa. They can also, glomerulonephritis, as all those immune complexes clog up your glomerulus in the kidneys, and then aplastic anemia. So it can also strangely attack the bone marrow and shut down the function of your red blood cells. So now let's talk about treatment. So you got this patient with acute hepatitis. As we kind of already described, very rarely does it actually progress, especially if you're an adult. So typically the focus is to vaccinate everybody in the household so they don't get it, and vaccinate any sexual contacts that they may have. So it's more about preventing spread. However, with that said, there are some indications for treatment, especially for patients who are at high risk for progression to fulminant liver disease. So, one category of patients we'll treat is people with severe protracted course. So people going for like 6-8 months and they're still not getting better from acute hepatitis, go ahead and treat them. They're having trouble fighting it off. Again, INR greater than 1.5, or even bilirubin that is elevated, especially if it's elevated more than 10, because these are poor prognostic signs. You want to treat these people. Individuals with weak immune systems, of course, they won't be able to fight off the virus as well. Like we already described, a co-infection with hepatitis C virus or co-infection with hepatitis D virus, just go ahead and treat them. Individuals with underlying liver disease, as you could imagine, they need to be treated. And elderly, because of course, they can't mount a fight against the virus either. So what would you treat with? So it's a lot of meds, specifically antivirals. So things such as tenofovir or entecavir, you can use that as well. And you can also use lamivudine or telbivudine, all antivirals that you can choose from. So continue to give them the medications. You'll check the surface antigen, and then you can discontinue after the surface antigen is negative twice, and you typically wait 1 month between those two checks. Chronic hepatitis is also found in patients with hepatitis B, and this is what we're very much afraid of and what we're trying to prevent. Clinically, the primary thing to remember is chronic hepatitis is diagnosed when the surface antigen is present for more than 6 months. So this is the definition. some patients will have a previous symptoms of hepatitis B, but keep in mind that's not necessary. And they may have been one of those patients who were just subclinical, which is actually a majority of patients. From a symptoms perspective, they do have symptoms that are just kind of related to chronic liver disease. Hepatitis B in of itself doesn't have any symptoms outside of that. And we'll just take a quick moment to kind of look at a lot of the symptoms that patients with chronic liver disease, especially cirrhotic patients, will often have. And so, for example, they'll have that scleral icterus. They tend to develop these spider angiomas. They have gynecomastia here. You can see this significant ascites with the development of the caput medusa. They also develop a little bit of pulmonary erythema, and you see this significant edema. So, one of the devastating points of having this chronic liver disease and cirrhosis is it affects the entire body, and it's just very devastating for patients to manage. From a lab perspective, ALT and AST can be all over the place. It can be mild to moderately elevated, or anywhere up to 50 times the upper limit of normal. So really, and ALT, AST is not really a good measure of monitoring, how active the virus is or how much liver damage has already occurred. The HBV DNA is a good marker for viral load, and that's actually going to give you a better idea of whether that patient is at high risk of developing cirrhosis or even hepatocellular carcinoma. It also helps predict whether they'll have a weak response to interferon, because again, a high viral load means it's going to take much more to get it under control. The envelope antigen for hepatitis B is also beneficial here. Again, like we've kind of described, it measures the replication and transmission of the virus. So when it's elevated, it means the virus is rapidly replicating and it's kind of wreaking havoc. And if it's low, that means, hey, it might be a little bit under control, even up to the point of dormancy. Patients with chronic hepatitis and just chronic liver disease do need screening for hepatocellular carcinoma, and this is done in two ways. One way, ultrasound plus or minus the AFP, and you do this about every 6 months. Fibrosis testing, which kind of tells you how much the patient is progressing to cirrhosis, should also be done, and this can be done with a process called elastography, or you can even use a liver biopsy, and this is typically done not just for cirrhosis or for fibrosis, but if you're gonna go and take a look at a mass, anyways, you can also diagnose cirrhosis through this, or the degree of fibrosis. So treatment does become more important in chronic hepatitis than acute hepatitis. So treatment depends on whether or not they have cirrhosis or not. Typically, if they have cirrhosis, you do want to be a little bit more aggressive with treatment because you want to prevent it from progressing and you want to prevent them from developing hepatocellular carcinoma. So if they have compensated cirrhosis, a good treatment option is interferon, which is given for up to 48 weeks. For patients with more decompensated cirrhosis, interferon is unfortunately not available for them. They have to stick to like the nucleosides treatments, and this is given for 4 to 5 years and may have to be given indefinitely, just because you don't want these decompensated cirrhosis people to continue decompensating. Now, patients without cirrhosis, you don't always treat. You treat based on whether the envelope antigen is positive. So if the envelope antigen is positive, you would treat only if the viral DNA load is more than 20,000 and the liver enzymes are 2 times above the upper limit of normal. And if the E antigen is negative, then you're going to treat if the viral load is more than 2,000 and the liver enzyme, the ALT, is more than 2 times the upper limit of normal. And you want to treat with the E antigen negative because sustained remission is actually more rare in that case if without treatment. So treatment has been shown to provide more sustained remission. And so what's the goal here with chronic hepatitis treatment? Well, you want to produce what's called a sustained viral response, which typically means that the HBV DNA is undetectable, which means there's no viral load. Your surface antigen and your envelope antigen is persistently negative, And finally, if you can get those envelope antibodies to develop, that is a very strong sign of remission and definitely one of the goals when we're treating a patient with chronic hepatitis. So now that you have a good understanding of what this disease means when you contract it or when your patient contracts it, let's talk about how this could be prevented. First thing we'll talk about is the hepatitis B immunoglobulin. This is something that you give to patients after they've been exposed to reduce progression to acute or chronic hepatitis. So the immunoglobulins are just a surface antibody, and they provide protection from anywhere from 3 to 6 months. Ideally, you want to give it within 24 hours after exposure, but if for whatever reason you can't do it that soon, you can give it up to 7 days. However, the earlier the better is the rule. There is a vaccine, so we're very fortunate to have this hepatitis B vaccine. You give this to infants at the time of birth and all adults less than 60 years old. It consists of 3 doses, so you give it, at 1 and 6 months after the initial dose. Some patients do need boosters, and these are specifically individuals who are on hemodialysis or they have a weak immune system. So these two patients give a 4th dose. Some scenarios to look into. So in the situation where you have a mother who's pregnant and she's surface antigen positive, the moment that she has a child, you want to vaccinate the child and give them immunoglobulin within 12 hours after birth. So this is important because it can reduce progression substantially to acute or chronic hepatitis B. If someone has sexual contact and they're not vaccinated, just go ahead and vaccinate them. That is protective, but of course continue to monitor, to do the kind of the STD workup as well. Needle stick injuries are very, very important to be aware of. There are going to be several questions on the USMLE. It's very, very common. So the approach is first to look at let's just say the healthcare worker who had the needle stick injury. So it depends, what you do depends on whether the healthcare worker was vaccinated or if that healthcare worker was unvaccinated. So let's just say the person was vaccinated. So there's 2 different ways to go based on whether their surface antibodies are greater than 10 or less than 10. So if it's greater than 10, that means that, hey, they're immune. And even if the patient did have hepatitis B, they're good. And so there's nothing to do. So if the healthcare worker is vaccinated and the surface antibody is greater than 10, nothing to do. Now, if they're vaccinated and the antibody is less than 10, well, that means, great job if you got vaccinated, but unfortunately, he's still not immune. So in that case, you do want to give some immunoglobulins twice, about 1 month apart. So that person would get immunoglobulins just to kind of boost his immunity. Now, in the unfortunate case where a patient, a healthcare worker gets a needle stick injury and they're unvaccinated, well, it depends on the patient. So you're going to look if the patient is surface antigen negative, meaning they don't have hepatitis B, or they're surface antigen positive, or for whatever reason we don't know, the patient refused to get checked, or they left, or whatever the case may be, we don't know the patient whether or not they had hepatitis B. So if they're surface antigen negative, that should be reassuring because that means they don't have hepatitis B, but you do need to get that individual vaccinated because if they got a needle stick injury once, they can get it again. And if they're surface antigen positive or we're not sure, very scary situation as you can imagine if that happens to you. But you want to go ahead and vaccinate and give them immunoglobulins just like that, the child who's born to a surface antigen positive mother. So hope this helps. Be sure to spend some time on needle stick injuries. It does come up pretty frequently. And I hope you enjoyed the video. And please stay tuned for my future videos. Have a great one.